Well, anyway, welcome to Wave Club. Thank you for bearing with Irfan and me while we were working through some of these technical issues. This is a summer version of Wave Club, so I'm really happy to have you all here with my partners in crime here running this discussion group, Bart Ehrmantraut, Uma Mohan, and Irfan Zabeh. Um, uh, as many of you may know, Wave Club is like an interdisciplinary journal club that we have with different speakers touching on the topic of traveling waves in the brain from various different areas of neuroscience, human neuroscience, what I do, animal neuroscience, computational neuroscience, electrical recordings, optical imaging, clinical work, or basic research. Anything that talks about traveling waves in the brain are things that we're interested in. And today we're going to hear um, from Michael Wenzel from Bonn University on hippocampal spreading depolarization as a key epilepsy disease factor, which is really a study that's going to look at the role of traveling waves related to epilepsy and things like that. So we're happy to have Michael here. I realize it's the summertime and there's a break for many of you guys, so I'm happy to have everyone here. Today's Wave Club is going to be a little bit less formal. We're not going to use the Q&A system due to some technical issues. So please just jump in, and Michael's going to begin his talk, and he's going to plan on presenting for 40 minutes like normal, and then we have time for Q&A at the end. But if you have questions, Michael said he's very welcome to take your questions in the middle. He can kind of manage things informally. So please just jump in and start talking, or use the chat. We can kind of feed questions to him as time goes on. Just a reminder before Michael begins his talk, our Wave Club talks are recorded on the YouTube channel. Go to youtube.com/@WaveClubSeminar. We also have them all listed on Blue Sky and also on Twitter too, I believe. We're on both, right? Here are the logistics, which I talked about a moment ago. And just to introduce you to Michael Wenzel, our speaker today. He's a professor at the University Hospital of Bonn. He's an MD PhD in the Department of Epileptology. He was here at Columbia University for a few years doing a postdoc with Rafi Yuste. He does work in epilepsy, cell level in vivo imaging, network electrophysiology, and epileptic micro networks. And before I turn the screen over to Michael, I just wanted to give you a quick preview of the coming speakers that we have for the fall. We have a really great schedule that's been organized with Krishna Jayant, Vishnu Srikumar, Pulan Gong, Mark Kramer, and Jun Young Moon, all presenting on their work throughout the fall and winter. So that's really exciting. Irfan and Uma did a wonderful job putting together this list of the upcoming speakers. So thank you to both of you for all of your help organizing this. You guys are wonderful partners in Traveling Waves. So thank you for your help with that. I think that's all I need to say logistically. And I'm going to turn this screen over to Dr. Wenzel, unless I missed anything, Bart or Irfan or Uma. Good. Okay. Michael, thank you again for coming. I'm looking forward to your talk.
Thanks for having me. It's a pleasure to be here. Also, it's great to see that Krishna is giving the next one, because we were part of the same generation in the USTA lab, actually working on very different things, but then also working together on some projects. So that will be a great wave club.
That's cool.
So yeah, thanks for joining in. It's about waves again today, but waves that are like many thousand times slower than the ones you most typically talk about. I'm just playing around with gallery here. Okay. Yeah. And so yeah, thank you for this kind introduction. My lab is trying to practically link very fundamental brain dynamics with a cellular scale recording techniques ultimately to clinical symptoms. And today will be about hippocampal spreading depolarization as a key epilepsy disease factor. It's an understudied phenomenon, and we also stumbled upon it, which is why this talk's a little bit inverted. It has a few introductory slides, of course, but then the heart of the issue, spreading depolarization, I'll deal with it at the end, actually. But maybe that also sets up the discussion well. So let me start this. Okay. we've studied epileptic networks for a long time. It's been around 100 years now that Hans Berger introduced the EEG to humans, and many things have changed and evolved since then. For example, it's not allowed anymore to smoke in the operation room when you're getting operated on. And also there's been new technology in the meantime, such as intracranial electrodes, grids, and this has improved massively also way beyond what I'm showing to you here. But nonetheless, despite all this progress, most of the very basic questions revolving around epilepsy have remained unsolved, such as how does a seizure start, how does it stop, how does it spread, why does it only occur every here and there, not all the time, and inversely, why does it not stop in status epilepticus? And my lab is also particularly interested in linking these very basic epileptic brain activity dynamics at cellular scale to field potentials and ultimately clinical symptoms. And so there's still this unmet clinical need in getting a much better understanding, basic understanding of these epileptogenic and ictogenic brain networks. Epileptogenic standing for practically such that promote epilepsy as an entity, and ictogenic that lead to seizures. The ictus is a seizure. Now, why is this important still? Wait, I'm constantly, okay. In the clinic, we have all these ill-defined terms. We have a so-called seizure onset zone that's quite frustrating sometimes because we don't really know where it is. We put up hypotheses, and then we have irritative zones and other types of zones. And in the end, we have to take hard decisions as clinicians. For example, in refractory focal epilepsy, is it possible to identify a single generator of seizures, and can we cut it out, for example? And here you see a nice illustration of our multimodal approach, where we combine EEG or MRI, PET imaging, intracranial grids, and a lot more diagnostic tools. But you also see that what they identify as seizure onset zone is not congruent. So it's quite discongruent sometimes. It makes it hard for us to decide what it is. And it's important for patients, because if we're not able to identify these generators, their likelihood, if we proceed to surgery anyway, because of our hypotheses, drops in half and becoming seizure-free afterwards. And this discongruence is not just because different techniques, it's also because we still have no clear understanding of these networks, really. On the other hand, for 100 years, even longer, the whole field, also clinical epileptology, has revolved around epileptic seizures. It's a hallmark symptom of epilepsy, of course, it's for a good reason. You see one here from our own department, from intracranial depth-electrode. And the whole terminology in epilepsy research, also clinical epileptology, revolves around the ictus: pre-ictal, post-ictal, peri-ictal, inter-ictal, and so on. So the seizure is the main reference point in epileptology, and it was also for myself as an epileptologist. And then we stumbled upon different phenomena that are quite understudied or play no role currently in clinical epileptology, despite probably their massive relevance. So there are conditions in the clinic that I still need to get this with my arrow. It doesn't really work. 1 second. Okay. There's the post-ictal state in the clinic, where there's different symptoms that can be life-threatening, such as post-ictal wandering. That's a prominent one that mostly is observed in temporal lobe epilepsy. It happens after seizures. It lasts typically minutes to dozens of minutes, where people walk around unaware. They can't remember, and but they show increased signs of locomotion. So they walk on a highway sometimes, and then police picks them up. When they wake up, they don't know how they got there. And then there's other symptoms, such as post-ictal aggression, that one of our rooms in our department had to experience recently. Again, this room got completely demolished. The person doesn't remember, but it's a relevant symptom, as you can see. For post-ictal wandering, I'm just showing you one of my patients also to illustrate this beyond just an AI-generated image that has temporal lobe epilepsy and has a history of post-ictal wandering after seizures. And this person is alive. He's lucky to be alive, but he's jumped off his balcony multiple times already and is full of metal practically. So this is just to illustrate you that these symptoms can be life-threatening. They outlast the seizure duration, which is typically just minutes by far, right? And it's not easy to also explain why a seizure in itself would have these lasting clinical effects that then resolve. It's a little bit odd still, but the clinician's reference to it. Okay. There's a number of post-ictal symptoms that are known. The list is long. I just gave you two prominent ones. One that plays a little role in clinical concept is SUDEP, sudden unexpected death in epilepsy patients, where there's basic research evidence that there are seizures that come with so-called spreading depolarizations that enter the brainstem and lead to cardiorespiratory arrest. And that leads to death if nobody resuscitates you. These symptoms play out on different time scales, such as seconds to minutes or hours or even days to weeks. There's post-ictal psychosis, for example, that can last for a long time. I'll be talking about these immediate post-ictal effects today. The phenomenon is also not new or anything. It has been described a long time ago by Charcot, for example, in his Leçons du Mardi de Salpêtrière in 1889. He described a case of ambulatory automatisms of, as he described it, completely morally sound person, reliable, always came to the job early, 3 kids, everything perfect, but then would have these episodes where he would wake up all of a sudden in a different district of Paris or actually immersed in the River Seine without knowing how he got there. And so this is not new, but it's fair to say that to this day, the underlying neurobiological mechanisms are unclear. Now, one slide about anatomical scales of recording. On the left side, EEG and MRI that cover the entire brain but have little spatial resolution. And you can improve this even in humans by implanting electrodes, say up to microelectrodes such as the Utah array here, that gives you single cell resolution already, but relatively sparsely still in comparison to, let's say, optical techniques such as two-photon microscopy that allows to sample from very densely packed neuronal networks and different cell types at the same time. And that's what I've been doing. Also together with Krishna, Giant, in the Houston lab, with my postdoc, where we practically embarked on an imaging seizure spread in the neocortex in the living brain using in vivo two-photon calcium imaging, which is what you see right here. So all these little dots that you see here are neurons. Sometimes you can see a black dot in the middle, that's the nucleus. So we do have cellular resolution or even micrometer resolution using this technique, and can image within cortical layers or also across cortical layers, for example, using glass microprisms that we implanted that deflect the laser beam at 90 degrees, and then you practically look at the living cortex from the side. So here you see that the layer 2 free, the apical dendrites of layer 5 pyramidal cells. And you can study this during seizure spread using imaging plus electrophysiology as we did. But when I came back to Bonn, I wanted to set up something new because all of what you see here, exemplary, were seizures that were acutely induced by local injection of a chemoconvulsive in the healthy brain. And in the ideal case, we would use something that has more value to reality using models that mimic realistic scenarios. And that's what we did when I came back to Bonn. We set up a model with a viral encephalitis, where we inject a picoRNA virus in one hippocampus. We also set up field electrophysiology plus chronic cranial windows, either for imaging in the neocortex or in the CA1 region of the hippocampus. And we imaged for months on end, actually. In the beginning, during viral encephalitis, we would image every day. And this viral encephalitis induced by this picoRNA virus is a nice model because it's primarily non-lethal viral infection of the brain. It comes with seizures, and those mice that develop seizures during the encephalitis have a high chance in developing temporal lobe epilepsy down the line. You can see one example on the lower left, where you can see the window implant above the hippocampus, and in the contralateral hemisphere, you can see a mock injection 3 months prior to this image, and the hippocampus is fine. But if you inject this picoRNA virus, this hippocampus becomes massively transformed. It's practically gone. It's replaced by GFAP positive cells. It's like an astrogliosis, a massive one that reflects hippocampal cirrhosis and temporal lobe epilepsy quite well. And now I'm going to show you a paradigmatic video plus LFP recorded at the contralateral hippocampus, but for seizures, it corresponded quite well. So the top part will be the average population signal on calcium, and the bottom part will be the field potential, and you also see the video. You see, I'm playing this a little faster, but you see the oscillation, you see the CA1 region of the hippocampus, densely packed pyramidal cell layer, cellular resolution. Now you may think it's over, and then there's this second massive wave. Actually, it's 2 waves entering the field of view that follow the seizure. And then, yeah, everything's bright. Nothing's oscillating anymore. And if you wait long enough, you see that the signal slowly but surely disappears. And this is perfectly consistent with what's called a spreading depolarization, a large depolarization wave that then is followed by depression, which is also the case in calcium imaging. So now if you wait a number of minutes, this network will recover and the cells will blink as they did before the seizure. When my students see this the first time, typically they think there's a technical issue, and then they check the objective and so on. But it's true. We also checked it with different methodology that you get this depressive phase in the network after this depolarization wave in the hippocampus. And just to illustrate that I'm not cherry picking here, I'm just showing you a bunch of movies across mice now. All of this is the CA1 region during encephalitis. So these are naturally occurring seizures in the awake mouse. And I hope that you can also appreciate that every time there's a seizure in the hippocampus, you see this second wave, or actually this multiplex second wave. Whereas when we imaged in the neocortex, and these are the videos I'm showing now, which we also did, we would get full invasion of territories and also these oscillations, these ictal oscillations. But then you wouldn't see the second wave. And that was surprising to us. It's also not to say that this does not occur in cortex. I'm always stressing this. Of course it can, and it does occur in the neocortex as well. But there are certain propensities of different brain areas. And in our case, the effect size was 100%. We always saw the spreading depolarization wave riding on top of seizures in the CA1 region, and we never saw it in the neocortex. And what you can also see here on the lower left, for example, is that you do not see this massive second wave in the LFP. And that's because of the bandwidth. And that brings me to the next slide. Just as a quick recap, what we see in the clinic, this is a electrographic seizure in a mouse with different high pass filters. And 0.5 hertz high pass is what we have in the clinic as a standard. So this is what we typically see. You see a seizure and then you see a flat line. We also call this post-ictal depression sometimes. And now if you lower this high pass filter, all of a sudden you get this massive second phenomenon here. This is the spreading depolarization that you cannot see, at least in the raw signal. And we haven't seen it in the clinic as a discipline for a long time due to this standard. Now I'm showing you all the imaged seizures that we captured across a few years in the hippocampus in blue colors, all the hippocampal ones, and in green, the ones in neocortex. And you see that every time there's this big wave riding on top of the seizure. And in the neocortex, that's not the case. Interestingly, both these regions, whether or not they were invaded by SD or not, didn't play a role. Both were depressed afterwards in terms of basic fluorescence, but the recovery time to the pre-ictal fluorescence was much longer in the CA1 region, where these SDs happen all the time. Whereas in neocortex, it would be very fast. It's less than a minute, and then the network is blinking again and seems grossly fine. Then we also looked at the spatiotemporal trajectories of these waves, and first within mouse. So we would, let's look at L first here. We would have a number of seizure trajectories on a cell-by-cell analysis practically after extraction of a signal. And then we would, between anterior, posterior, lateral, and medial, we will get some vector, and we would get a number of trajectories, a mean trajectory, and then of course a standard deviation, and to investigate whether these trajectories repeat. So if there are repeated patterns of progression of seizures versus the first seizure-associated SD, SSD, I call it, and the second wave, we took these observed standard deviations, which you can see in K now, in the top panel, for example, again, across mice, where you would see an observed value, and we would compare it to random standard deviations of 1,000 repetitions of randomly created STs. And you see these shuffled distributions, and all of them were statistically significant. And to a lesser extent, that would also be the case for the first SD wave, that's the one in the middle, and lesser to the second wave that you see on the right. Now, when we looked at this across mice, all of them were significant, and that's also interesting because it shows that it's not just consistent within mouse at whichever direction, let's say, but actually these neuroanatomical directions are conserved to some extent. For example, in our case, and you may have seen this also in the videos already, the seizures would progress from the CA1 to the CA2 and CA3 region, and the SD would always travel the other way, or mostly travel the other way. That's what you see in M. The angles were huge. So we would have intuitively hypothesized that they travel the same direction, but they would always come the other way. Now, interestingly, we also looked at very basic behavior, in this case, locomotion, because these mice are sitting on a belt. And here you can see the raw locomotion signal across mice and events, all aligned by the optical invasion of the seizure time point. And then in the second green mark is when the SD shows up. And what you can see with the naked eyes is the raw signal, is that these mice start running after this event, right? We quantify this again. For example, looking at percent time locomoting, travel distance, and so on. And all of them were statistically significant. And when I was sitting there as a clinician again, looking at these data, I didn't have in mind actually studying these waves. We wanted to study seizure spread and mechanisms related to seizures, actually. But it made me think of post-ictal wandering in the clinic, because these mice would always start running and would be correlated to the onset of this SD wave, not the seizure per se. During the seizure, they would typically show some behavioral arrest. Now, the issue was that we could not dissociate seizures and SD in this model because they would always co-occur. We had no chance in finding out whether it's the SD or the seizure. And so we set up an optogenetic framework, either using two-photon microscopy and electrophysiology as before in combination with optogenetics, or bilateral optical cannula without imaging plus field electrophysiology. And that also works quite well. I see a question, Ethan.
Yeah, I keep it short, but is there any behavior or behavioral properties in the running post-ictal that makes you confirm it is caused by post-ictal activity, or how do you distinguish it from regular running of the mice?
Well, I have the running before the event, right? So we typically quantify 5 minutes of locomotion behavior before the event, and then we compare it to 5 minutes after the event. And this is how we quantify the differences. Here it's even more clear because what's interesting is these mice are now healthy, right? Still, nothing is easier than inducing a seizure in the healthy mouse. So this mouse would show some baseline locomotion over a number of minutes, and I will show you that in a second. And then we could compare to the post-event locomotion. And here, using optogenetics now, you can see that a short light pulse can easily induce a seizure in the hippocampus. And then interestingly, I found it interesting that every time again, you would get a big second wave, the SD. And you would also see this in the contralateral hippocampus that would also have its own SD. And just for reference, again, in the clinical recording, you wouldn't see it if you filter it according to the clinical standard. Now, if you keep the light on, so you're practically clamping down that network, it cannot oscillate anymore, just keep the light on, you depolarize cells with channel Rhodopsin 2, you can induce this SD wave separately without a preceding seizure. And what you see here is just locomotion artifacts. You cannot perfectly erase them, marked in gray, but you see in the spectrogram that there's neither a seizure nor any spectral depression afterwards, which you can nicely see on the left side. And this is what this looks like now in healthy mice. That's the hippocampus again, CA1 region. I'm playing this a little bit faster, but you can nicely see that there was this oscillation, and now you get the second wave again. It's multiplexed again. And you can also induce this phenomenon in an isolated fashion. So here you see the wave spreading, and there's no preceding seizure. And then that's what Efan just asked. Also, we quantified 5 minutes post versus pre-stim versus control stimulation. So we would also apply light to these mice, but at a different wavelength where it doesn't stimulate the opsin. And then typically when mice are sitting on the belt under control conditions, they tend to either obviously run the same amount in a continuous fashion, or they tend to run less because they get bored on the belt. They know the belt, and the longer they sit on the belt, the less they want to run. Now, if you do a simple subtraction, you would assume that it's around 0 or less than 0 if they run less, and that's exactly what happens in control. I'm only showing you 2 parameters now. We, of course, looked at a number of different parameters too, just as before. And now, by SD in a unilateral fashion, we could already recapitulate this locomotory phenotype that we saw during viral encephalitis. And interestingly, though, we saw that when there was a seizure that was associated with natural SD, because we didn't stimulate it, but it would follow the seizure anyway, the effect size would even be bigger. And what you see here is actually the work of a year of experiments again, because then we had to add experimental series where we checked out other conditions to find out what was the case. Our hypothesis was that when you look at I again up here in the middle, when you induce a seizure in one hippocampus that then is followed by SD, you will also get a seizure in the other hippocampus, which will also be followed by SD. So if you induce SD in a single hippocampus, it's an unfair comparison to compare it against seizure plus SD, because that would be bilateral, no matter if you induce a seizure in 1 or in 2 hippocampi. So we checked that. That was the same. But when we induced SD bilaterally in both hippocampi at the same time, we would get the same effect size or bigger effects with SD in comparison to seizure plus SD. And so we thought that's great. That practically shows us there's no additive or any other effects that tell us that it's seizures themselves. It's the SD that's driving the phenomenon. But then, of course, the reviewers asked us to do something that is hard. Namely, they criticized that we hadn't shown we had recorded before. It's a rhythmic activity, and also it shows evolution in frequency, amplitude, and ideally in space. And so we titrated our stimulation such that we could fulfill all these criteria. I'm showing you one example here. That's LFP now, no imaging. And in the bottom, you see our stimulation. And we change frequency, amplitude, and so on. And at the top, you see the LFP signal. And we could titrate it such in every mouse that we could stay within a corridor where we do not get SD afterwards. And when we did this in a number of mice again, this is just the parameters that we used that fulfill these official ACNS criteria. It worked quite well, I have to say. So we could induce either in AAV-mediated channel gene expression or in transgenic mice, we could induce SDs repeatedly again, or these so-called seizure mimics or seizure-like episodes. And in control simulations, you would never get any of those patterns, no matter what you do. We quantified them again, just as we did before with viral encephalitis and these other optogenetic experiments. And what we found was that when we compared control to these seizure-like events, they were always similar. Across all quantified parameters of locomotion, these seizure-like events would not produce the phenotype, whereas SD would reliably as before. And that to us was then the best thing we could do to show that it's SD driving these post-ictal symptoms and not the seizures themselves. And that is, at least to myself also as an epileptologist, fundamental, because we've been referring maybe to an incorrect entity for many of these symptoms for a long time. Okay, all great and fine. This was mouse, where we have a lot of control over certain parameters. Is there any relevance for clinical epileptology? So we went on and looked at some of our depth-electrode recordings in human patients. This is one example where we implant depth-electrodes in a number of regions. This is an ATAC electrode carrying 8 macro contacts across depth, and then you have a microwire bundle at the distal end of it. That also gives you spatial cellular resolution and the ability to record really local field potentials. And here on the right side, you see just a recording of these microwires alone, not the macro contacts. And what you can see very nicely in the context of this electrographic seizure is this very slow shift at the end that's confined to the anterior hippocampus. And you cannot see it in the other regions. I'm just showing you zoom here so you can see it better. This is a 0.1 hertz high pass filter. It's an AC coupled recording. That's the best we could do in our current setting. But still, you can see this shift that lasts a number of seconds, outlasting a normal oscillation. And when we quantified where we could find these slow shifts, they only happen in a set of 4 patients and 16 seizures in the temporo-mesial regions. So only the amygdala and the hippocampus, and not in the other regions. Again, this is not to say that this does not happen in other regions, but it was interesting to see that there seems to be a propensity to the temporo-mesial system, which is affected in temporal lobe epilepsy very often, which is where we most often see these protracted post-ictal symptoms, such as post-ictal wandering. Then we quantified these regions again, and long story short, also at the unit level, regions that are affected by the slow shift show a stronger depression of spectral power in comparison to those that are non-affected, and they take longer to recover, just as we had seen in the mouse. Okay, now this leads me to the summary of this project, where we found these seizure-associated focal spreading depolarizations with profoundly different regional propensities, and also their spatiotemporal characterization was interesting to us because a number of aspects around them were non-intuitive. We could show that these SDs trigger post-ictal ambulation, while the seizure mimics that I showed you do not. And we could find these focal slow shifts in human Behnke-Fried electrode recordings at seizure termination. Now, this sets off a number of questions on the general role of SD in epileptology, not only related to post-ictal wandering, but also to other symptoms such as TOTS paresis, where we have reflexive paresis that is transient and goes away, or post-ictal confusion, or SUDEP, as mentioned, and many other symptoms that we know. It also has implications for epilepsy research because most of the time, the research does not distinguish between seizure and SD, they lump them together. And so it could very well be that some of the effects and effect size that have been reported are practically attributed to the wrong entity. SD is in many ways the antithesis to a seizure, because a seizure is an oscillation and SD is the breakdown of the membrane potential without any oscillation. It leads to the question whether we should revise this clinical EEG standard because the bandwidth precludes us from seeing these events. And more fundamental questions, because we always talk about pre and post-ictal also at a clinical level. But if different regions can experience seizures while others already experience SD, and so on, this can lead to compound signals and semiology at the clinical level that need to be attributed to very different underlying dynamics. So it's no longer easy to talk about which semiology is produced by what. Now I'm coming to the beginning, practically, because the question is, that's what we asked ourselves, of course, when we first encountered it. What is spreading depolarization? And then there's a number of definitions that we don't need to read in full here. Liao first described them in 1944. And he described them as an enduring reduction of spontaneous activity. So he emphasized the depression part of it. Then there were a number of other influential figures, and the definition grew more complex and complex with time. Sorry, one second. And then in the end, it became a little bit simpler again, because most people now describe it as a depolarization wave, and the depression is an epiphenomenon of this depolarization wave. And most people call it spreading depression and depolarization these days. But the debate is ongoing, what it actually is, and these two sides of it, the depolarization and depression part, because it doesn't necessarily need to occur, depending on the circumstances and the local tissue parameters. In electrophysiology, SD is a contiguous slow wave that propagates very slowly, like many thousand times slower than the typical waves, traveling waves you talk about. So it's a few millimeters per minute. It's a depolarization wave that has an initial gamma range oscillation that lasts a few seconds. And you also saw this in our recordings, or here at the bottom. That depolarization goes above the inactivation threshold in the prototypical case, and is then followed by depression. And then, depending on the local tissue circumstances, you get recovery over minutes or longer timescales. Many different things can stimulate SD. That's interesting, from mechanical stimulation, electrical stimulation to gene mutations. You name it, very different triggers, and also very different diseases, neurological diseases come with spreading depolarization, very different contexts. So it's something that seems to be fundamentally there, at least in neurological disorders. And there are certain similarities also between epilepsy, migraine, even certain genes that link the two. But it seems to be a fundamental entity. This can be recorded with EFIS or with imaging. Here is just light transmission in a slice, where you very nicely see this concentric wave that you also saw in our recordings, but we've seen that before. I'm skipping this. There's a few things you need to consider when you want to record it, because you cannot see it with a certain bandwidth. But you can still see it with very low high-pass AC recordings, but then obviously the morphology will change. Here in the middle, you see recordings where both DC and AC recordings were carried out at the same time of the same event. And you see that this large signal disappears pretty quickly, but you can still see it. And that opens a window, so we can also look in suboptimal recordings in the clinical setting and still identify them, hopefully, with the use of additional parameters such as spectrogram, recovery rates, possibly other modalities, and so on. Where can you induce SD? In many places. Practically, you can induce them anywhere in the brain with certain propensities for the phenomenon. For example, the hippocampus shows a higher propensity, it seems, and some that are less prone, such as the olfactory bulb or the cerebellum. But quintessentially, you can induce it anywhere in the central nervous system. There's many pathophysiological implications of the phenomenon that may actually go way beyond the seizure themselves. And it's just a list. We don't need to go through this, but it comes with a lot of implications for the immune system, for neurons themselves, for other cell types in the brain, such as glia, and so on. We hypothesize that this phenomenon plays a quintessential role also in epilepsy. Finally, there's an ongoing debate about the beneficial or deleterious nature of this phenomenon. So there's been a few papers that have communicated a beneficial role. For example, in this recent paper by Andrew Boyce and colleagues, they used the hippocampal stroke model in rodents, and they showed that in the acute phase, SDs would be deleterious, but 7 days post-stroke, only those mice that had SDs in the contralateral hippocampus would have an improved cognitive outcome. Could also be that SDs riding on top of seizures in fact mediate the positive effects in electroconvulsive therapy in neuropsychiatric patients, which is very interesting because it has been elusive why eliciting a seizure, again, everything refers to the seizure there, can produce long-lasting effects that sometimes these patients show improved symptoms for years after such treatment. So it could be SD. And then there's people, for example, from Cenkayata's lab, that also promote this idea of using SD that rides on top of seizures as an anti-seizure tool, or even evolutionarily conserved mechanism against seizures. Because as you've seen, whenever SD occurs, the seizure stops. That has been shown already a long time ago by Bujaki's lab, for example, and Anatol Bragin. But it's certainly the case that seizures stop. But the question is whether that helps you and whether you should use this as a tool. Then there's the other side where papers have shown that, again, in experimental models, that SD can promote tumor growth, for example, in neurobiology, in neuro-oncology. The SUDEP example we've talked about. And our paper practically links these SD to clinical phenomenology that can be life-threatening that, for example, Tamim and colleagues could not investigate because this was done in anesthesia. All right, and with this, I've reached the end. Thanks for listening, and thanks for having me. I'm looking forward to questions and discussion.
Thank you so much, Michael. I was going to start clapping. I saw Bart clapping there for a second.
Thanks.
Why don't we? We're not using the Q&A feature today. Why don't we just have people jump right in with questions? I'm excited about spreading depression.
It is certainly exciting to us.
Yeah, I have a couple of questions. First of all, so how long does the length of time it lasts differ in human from animals, or is it pretty much always the same? And this is a question I asked Mark Kramer recently, because we have a dog that has seizures, and they last 2 to 3 minutes, and then she's really out of it. So what stops the seizure and what initiates it?
So yeah, we will need some more time to figure this out. But so regarding your first question, interestingly, across species, the traveling speed of these waves is very similar. It's a few millimeters per minute. And it can be a little faster, it can be a little slower. It depends, for example, on the density of the tissue. For example, in densely packed CA1, it seems to propagate a little faster. But grossly, this is the speed. and the recovery from it is also pretty much conserved. I found it quite interesting to see that these mice, for example, they start locomoting for around 5 to 10 minutes, and then they stop again. And this fits very, very well with these immediate post-ictal symptoms that we encounter in epilepsy patients, where we typically just walk with them up and down the hallway, and then around a few minutes later, they clear up again and you can interact with them again. It's not necessarily so short, but mostly it is.
Okay, because you showed that guy with all the broken bones and you showed that woman walking in the highway. So that seems like it would have been more than 2 or 3 minutes.
That's true. Well, the guy with the balcony.
Oh, balcony. Okay. Yep. I guess. Okay.
It was his own balcony, so there actually the few minutes would be okay. But we also have cases where they tell you the last thing I remember is waiting at the bus stop, and then I found myself walking on the highway. So it would be like half an hour or something. These time scales differ, yes. So there's different levels to this. But the immediate post-ictal period, at least in mice and humans, as far as I've encountered them, are interestingly very similar. And with seizure initiation and seizure termination,
maybe just with the optogenetics. What are you actually stimulating when you initiate the seizure?
Yeah, actually, that would have been my answer. There's different levels. If you look at it from the cellular level, there's been different schools, actually. It's been running for a long time, and it took us some time to get these papers on board for a debate paper where everybody's on the same paper, at least, and they can say what they think is the case for cellular mechanisms of seizure initiation. If you stimulate interneurons in certain interneuron populations and you make them go off at the same time, that can efficiently trigger seizures. But the same also is possible when you stimulate pyramidal cells or mixed populations of cells, because obviously these are interconnected circuits. So there's no bad guy to begin with. I think the interneurons are just doing their job, but then at some point they're doing their community a disservice. That's how I see it. So in our case, we stimulated when we expressed AAVs, pan-neuronal. So in all neurons, this short light pulse of 750 milliseconds can very efficiently start a seizure in the hippocampus. And we also stimulated this in transgenic mice. And these transgenic mice run the channel rhodopsin under the Thy1 promoter. So it's sparser and it's primarily excitatory cells. Still, there are some inhibitory cells also that express it. It's harder to induce SD this way, but you can induce seizures also just as well. Yeah. And termination, again, it's complicated. I guess SD is probably one of the mechanisms that terminates a seizure. It's true, but it's not the only mechanism probably.
This reminds me of there's some old work by Cressman on depolarization block of inhibitory neurons. So is that sort of, there they did it by putting in, I think, 4AP or something like that.
Yeah.
And it causes these inhibitory cells to go on to a upstate where they don't spike anymore.
Yes. Actually, this is very complicated. And whenever I have discussions, for example, with, Rustem Kazipov and others on this phenomenon, people tend to say that this SD corresponds to a depolarization block. But you saw one of the images, actually, in my earlier slides. That's a paper I did with Krishna Giant, where we visually identified parvalbumin positive interneurons in the neocortex, plus electrophysiology, plus calcium population imaging of that same population, plus 4AP, as you just mentioned. And we practically have the PV information in vivo, and others have done this in vitro, where you see that whenever the seizure invades that territory and you see the oscillation, these PV interneurons go into depot block. So the depot block itself is not like a marker for SD. It's also different in a way that very typically these interneurons go into depot block, and then they slowly but surely throughout the seizure recover. You see these immature spikelets that get bigger and bigger towards the end of a seizure. So they recover very fast. Whereas SD is probably a homeostatic breakdown that goes beyond something like a depolarization block. I'm not sure if there's a term at the single cell level for this, but I guess that SD goes beyond a pure depot block in a neuron. Yeah.
Maybe a quick follow-up related to these, the locality of these waves. You're recording the LFP bilaterally here. It's hard to
Yes.
tell on this. So when you're identifying these waves, is based on the speed, if it's millimeter per minute, do you have different in the onset between different hemispheres, or is it happening at the same time in hippocampus? Or
Actually, I can go back. Yeah, it's interesting. When we induce SD in one hippocampus, it typically doesn't cross over to the other one, right? It's traditionally at least thought to be a gray matter phenomenon. It stops at white matter. And I showed you one recording actually where you can see it very nicely at the same time. With, here. This is from different hemispheres, right? You see the average population signal in the middle, in the top panel, the middle, with a short 750 millisecond pulse. That's one hippocampus. And then you see the contralateral one, and you very clearly see that these SDs have different timings. You also see that the seizure in one hippocampus is much shorter than in the other one. That's also interesting. So the oscillation itself, that travels nicely. So whenever you induce one seizure in one hippocampus, you get it in both in the mouse. So in the beginning, we actually did bilateral electrophysiological recordings, and we would always see it in both hippocampi. But the SD itself, as it is like a neighbor by neighbor spreading, as Bart pointed out in the beginning, it's non-synaptic. You can block synaptic transmission, it works just fine. No problem. But it typically doesn't reach the other hippocampus. So that's why it stays local. And we also did some experiments where we looked at the neocortex while we induced SD in the hippocampus. And typically it didn't travel to the neocortex either. But all these things depend, that's very important to keep in mind, depend on the scale of the seizure. There are some people that study these things in generalized tonic-clonic seizures, where you get massive activation across wider portions of the brain. And there you get SDs probably more widespread. In our case, it's a focal seizure, and then there's different brain regions that have different propensities in producing the phenomenon.
thank you.
Are there any questions or comments or ideas from the audience? I'm super happy for everyone to just jump right in.
I was always wondering when I talked to Mark, maybe I can make a comment about the complex shape of propagation, because traditionally it's always described as this concentric wave that travels through CA1 or the neocortex, and that's also what it looked like in our case. But then you get the second wave, so it's multiple waves, and the second wave very often has this scissor-like phenomenon. It's not a concentric wave. It comes in from several sides and then it closes in on a territory. So it may be a complex shape of some like spherical expansion in heterogeneous tissue hitting our imaging plane. But of course, I don't know. But I wonder what you would say about this.
There are Zhang Wu had a bunch of examples of waves induced in visual cortex where they would reflect off of other regions. So as you went from one region to the other, you would actually get a wave that reflected back. Now, these are not the SD type, but these are real, fast neural waves. But could it be anything like that?
That would be Yang and Woon, or what? Who would that be?
Zhang Wu.
Okay.
You probably know that name. He's at Georgetown, but
Okay.
he does optical imaging. I think he came out of Larry Cohen's group.
Okay, thank you. Yeah, I'll have a look.
Anybody else have any questions? Hi, Daniel.
Hey, have maybe a quick clarifying question. I'm trying to understand how is this the slow wave of the depolarization, how does it start, or is there any known mechanism of like what triggers it at the beginning? Yeah.
Good question. Obviously, we didn't stimulate it ourselves, right? There's all these triggers that you can use, but in our case, it was naturally occurring. And we do not perfectly know what starts it, but there is some literature, for example, by Helen Scharfman in slices. It's already a while back, but whenever she stimulated seizures in a slice, she would get these SD waves starting in the CA3 region or CA2 region, so not the CA1 region. And there are these so-called, that's what I think, I'm not sure if Bujaki named them this way, but these potential detonator synapses that can practically dump enormous amounts of glutamate on their postsynaptic cells. And that's especially the case in these regions, which is why it may be the case that CA3, CA2 have this massive propensity to create SD when something extreme happens, such as a seizure. And that fits with our in vivo data, right? Because these SD waves always came from the CA2, CA3 direction. We do not know, but that's how we discuss it in the paper, that maybe these detonator synapses are responsible for that.
It's also why you only see it in the hippocampus and not as much in the cortex.
Could be, yes. I mean, I've seen them also with two-photon imaging in the neocortex when we used 4AP, but that's a potassium channel blocker. So it makes it more likely for SDs to occur on top of seizures because you have high extracellular potassium. I also think that it's not only related to regions themselves and their neuroanatomy, let's say, but also lesion, right? I haven't really talked about this here, but there's probably a perilesional propensity of tissue to produce this because it's obvious it's damaged, right? That's also a reason why, for example, if you have a ganglioglioma in the precentral region, then these people very often get TOTS paresis after a seizure, probably because they get an SD in the precentral region. So it's not that the cortex cannot produce it. No.
I see. Cool. Thank you.
Thanks, Daniel. Any other questions or comments for a speaker? Okay, I think we should wrap up. Michael, thank you so much.
Thanks again for having me.
Summertime and when it's a little late in Germany.
Well, that's okay.
All right, well, thanks for your time. We look forward, if anybody is interested in, is not on the email list or wants to learn about future Wave Clubs, please send us a note. At Wave Club Seminar is our Blue Sky handle, right? Okay, yes, I got that right. And this session will be recorded and placed online for anybody who wants to review some things. Thank you, everyone, for your attention and interest in our seminar. Talk to you soon. See you next month. Michael, thanks again. Take care.
Bye-bye. Have a good one.
Bye-bye.